Good evening, everyone. Sorry for the interruption and because of the internet speed and all. Let's go ahead, keep the things rolling. Today we'll be discussing about the Aneuploidy screening. We know it's required and it's to be done for the Down syndrome, trisomy 13, 18, Patau, Edwards, as well as now we can also do this screening for the sex chromosomes, aneuploidies, as well as some microdeletions also during the aneuploidy screening test. Among them, but the most difficult one is the Down syndrome because it's difficult to pick and it's a real nightmare for the family and the nation because of the associated disability and the mental as well as physical cognitive abnormality. So what are aneuploidies? Aneuploidy is like when there is a presence of an abnormal number of chromosomes in a cell instead of 46, if the cell is having 47 or 46, 47 number of chromosomes. Why we need to do? Because they are associated, as we have discussed, they are associated with the abnormal physical and cognitive development. It occurs in around 3 to 4% of the recognized pregnancies. And we all have studied that the risk of the aneuploidy increases with the increase in maternal age. And among the aneuploidies, there can be trisomies which carry 3 copies of a particular chromosome, or there can be monosomies where there is a single copy of chromosomes. Incidence-wise, trisomy do happen more often than the monosomies because deletion of any genetic material is more lethal than the addition of the genetic material. The prevalence of a common aneuploidies per 1,000 live birth is like this, and as you can see from the table, trisomy 21 tops the chart, and then followed by Klinefelter and that double X double Y syndromes. As we have already, we all know that maternal age is associated with the increased risk of trisomies, and it increases with the increase in the maternal age and decreases with the decrease in the gestational age. As you can see in the graph, the association with the maternal age and the risk increases drastically after the 35 years of age, and as you can see in the adjacent table, it decreases with the age as the gestational age increases. So anyone who like in the 30, suppose a woman of a 35-year-old at the 12 weeks, she'll be having around 1 in 2 risk of 1 in 250, and towards the term it decreased by to around 300 and something. So the decrease in the risk with the gestational age do happen because a lot many fetuses, around 30% of the trisomy 21, do die in utero between 12 to 40 weeks of pregnancy. When you talk about the association of the other aneuploidies with the maternal age, trisomy 18 and 13 do the risk of them do increases with the maternal age and decreases with the gestational age. But the rate of the fetal demise in utero is far more than that of trisomy 21, and it reaches up to 80%. While the Turner and triploidies are not at all related to the maternal age, the rate of the Turner syndrome in utero demise is around 80%, and triploidy is very lethal, and that's why it's very unlikely to see a live birth with a triploidy. As you can make out in this table and in graph, the risk for the trisomy 21, 18, and 13 they increases with the increase in maternal age, but the triploidy and the Turners don't. So it was predicted, and during the in the early years of the around 1970s and 80s, only way to go ahead with the screening for was maternal age. So people were during that time period, they used to do a kind of a confirmatory test like a CVS or amniocentesis for those women who are conceived and who are more than 35 years of age. So if I go by the epidemiology of that era, that time around 5% of pregnancies do have to happen in women of more than 35 years of age, and that 5% of pregnancies contributes to the 30% of the trisomies 21. So if I go by the logic of doing amniocentesis and amniocentesis or CVS for those women who are conceived after 35 years, then I'll be doing the invasive testing for 5% of the pregnancies, and I'll be detecting only 30% of the trisomies. and let the rest 70% will be left undetected. And as the year gone by, passed by, more and more women have become career oriented. They are conceiving at the later gestation, at a later maternal age. Now the percentage of women who are conceiving after 35 years has increased from 5% to around 20%. And these 20% of pregnant women are contributing to the 50% of the trisomy 21 now. And if I go by the same logic to do the to do the CVS or amniocentesis for these 2 months, I'll be detecting only the 50% of the trisomies, and 50 will be remain undetected because the still those 50% are coming from the younger age group. So why we need aneuploidy screening? Aneuploidy screening is needed because the incidence, as we have come across now, that incidence is not very uncommon, and it is still it's around 1 in 650 live birth, and even in the younger age group women do contribute a big chunk of the trisomy 21. Second, the trisomy 20 baby born with the trisomy 21 has gotten a poor quality of live birth, and they, especially the trisomy 21, they have got a long lifespan, and they have to span that life with with low mental IQ, needing a supervision, constant supervision throughout the lifetime. So this is a kind of economic and the social psychological burden on the family as well as the nation. Second and most important myth which we as obstetricians have, that USG can pick up anything. It's not so. USG can pick up, have gotten a very low detection rate for the trisomy 21, and it's as low as 35 to 40%. That's why a lot many babies, if you just rely on the USG, a lot many babies with trisomy 21 you can miss on. And if I go by the logic of having an amniocentesis, doing amniocentesis and CVS for detecting trisomy, these invasive testings are risky because they carry the risk of abortions around 1 to 2%. They are costly, and still, if I go by that logic, it's really very insensitive way, because I can miss around 50, 60, 70% of the babies because of the not detecting the trisomy 20 which are coming from the younger age group. So we want a test which is non-invasive, which is low in the cost, and which carries a high detection rate with a low false positive and low false negative rates. The people who have contributed most in the evolution of the aneuploidy screening are these. As you all know, the John Landon Down in 1862 has coined and coined the term Down syndrome. Then Howard Stephen Chuckle, who has contributed most into the biochemical screening, especially the triple test and now the quadruple test. And now the one person who has done the most in the first trimester screening is Dr. Aneuploidy, who has devised combined test, NT and the combined test. So among the tests available to us, the performance of the various tests varies a lot. So if you go by the table, we have tests available for the first trimester as well as the second trimester. In the first trimester, I can go by this with the maternal age along with the NT only, and if I go by NT only, then I can pick up around 75 to 80% of the down babies, and shows me the significance of having doing an NT scan. A single marker can pick up around 70%. Such a remarkable, such a highly sensitive marker it is. If I go by, and the next option available with me is I can do the dual marker, like which carries which is we can do with the pre-beta HCG and PAPE, but it's a terribly poor test because it carries a very low sensitivity around 60-65% with a false positive rate of 5%. Next comes the combined test, which involves NT, pre-beta HCG and PAPE, and with this you can detect around 90% of the trisomies with a false positive rate of 5%. If you in the second trimester, you can do dual test, you can do triple test, and you can do the quadruple test. Dual and triple are kind of things are top of the yesteryears. They are not being used in, now. No more is used. Only option left in the second trimester is to do the quadruple test, which can have a sensitivity rate of around 75% with a false positive rate of the 5%. There are one few more things are there, fancy things like integrated testing, sequential testing, contingent testing, stepwise testing, but all those can achieve a good percentage. But the thing is that it carries, it has to be, the patient has to wait for a longer duration time, and then the false positive rates adds up to of the two things. So that's why the integrated testing and sequential are not much in the in fashion. So among the available, as we make out, the one with the combined test, which is a combination of a USC and a biochemical screening, where we can do the testing with anti, pre-beta HCG, and PAPA, can give us a detection rate, handsome detection rate of 90 to 93% with a false positive rate of 5%. Newer things have come up, and among them, one is the first trimester quadruple test. We all know that anti is something which is very difficult to take. It needs time to learn how to take the anti. Even if someone who is very skilled in the taking the anti, still at the same time they may struggle get the proper anti. And the anti should be taken as per the FMS criteria. Otherwise, it's of no use or no meaning. So uh, it, Nicolai's group again has come up with one newer test, which is called first trimester quadruple test. So the patient has to wait for the wait to go for the second trimester quadruple test. In this test, we can in the first trimester quadruple test we can do it's all completely biochemical screening only with the PAPA, free beta HCG, PLGF, and alpha fetoprotein, and gives us a cumulative sensitivity rate or detection rate of 74% with a 5% of false positive rate. So it's sensitive rate is as close to the second trimester quadruple test, and with this we can give the benefit of the to the patient of having a first trimester abortion if anything goes wrong in the testing. And simultaneously, it has got an additional advantage that we can pick up preeclampsia, PIH, IUGR, sudden death, and one additional thing is that this kind of testing is contingent with the two strategies, either by the NT or NIPT. So uh, if I set the logarithm for the uh, aneuploidy to the detection rate of 98%, then in the first trimester, if I do the testing with the first trimester quadruple test, then I'll be having 38% of the false positive rates. But if I add anti and ductus venosus to this, my false positive rate falls drastically. So, and with the 98% of sense detection rate and false positive rate of only 8%, this test becomes so powerful that it can replace the NIPT or the forthcoming newer technological test. The addition of ductus venosus and NT in this test can drastically reduce the need of the NIPT and invasive testings. Next test which has come up in the and is about to come in the world is first trimester pentalogy test. It's a expanded conventional first trimester testing, and recently in 2017 it was been this article has been published by the Nicolai's group in the prenatal diagnosis journal. Here what they have done, they have done a combination of a few USC marker and few biochemical marker. They have included anti with the nasal bone. Additionally, they have taken serum alpha fetoprotein, placental growth factor, and inhibin A. And this test is bit magical that it's having a detection rate of a 98% for the trisomy 21 and 95% for trisomy 18 and 13, with the false positive rate is minimum as 1.2 and 0.5. So with the use of this, it almost eliminates the need of NIPT, and invasive testing will be limited, will be done for a very limited percentage of the cases. But first trimester quadruple or this expanded first trimester screening called penta testing is still in the evolution phase and is not validated in India, is not available right now. So among the all available tests which we are having, the most effective method of screening is the combined test, which is a combination of maternal age, some biochemical marker like 3-beta-CG, PAPE, and ultrasound scan at 11 to 13 weeks to get the NT. These three combined together can give you a sensitivity rate of around 90, 87, 90%. But if you keep on including pure USG marker like presence of the nasal bone, facial angle, fetal heart rate, flow across the tricuspid wall, ductus venosus, and hepatic artery, then you can further enhance your detection rate by you can achieve as much as around 95 to 97% of your detection rate with a false positive rate of 2.5. So if by going this way, you can decrease the women who are requiring invasive testing from 15 to 20% to less than 3%, and you can increase the rate of Down syndrome and for other major chromosomal abnormality from less than 50% to 90 to 95%. So what's the physiology of doing a screening test? Screening test is to be done first of all. It's a thumb of rule that it should be done for universally for all women because every woman carries a risk of that her baby may have some chromosomal defect. So this risk which every woman carries is called background risk or prior risk, and it depends upon the maternal age and the gestational age. This patient and from the background and risk or the prior risk, it is also called age risk. We can calculate the fetus specifics by multiplying this age risk with the likelihood ratios of the various markers. The likelihood ratio for any marker, be it a sonographic marker or biochemical marker, is calculated by dividing the percentage of chromosomally abnormal fetus by percentage of normal fetuses with that measurement. So if I go for a combined test, the maternal age and gestational gives me the age risk. If I multiply this age risk with the likelihood ratio of PAPE, I'll get a new risk. With this new risk, I again multiply with the likelihood ratio of beta C, I'll get the biochemical risk, which is the double marker risk. And with this double marker risk, if I multiply with the likelihood ratio of the NT, I'll get the final risk, which is the combined risk. That's how it works. And along with the doing aneuploidy screening, 11 to 12, 13 weeks scan do carry other benefits like doing a scan at 11 to 13 weeks, we can accurately date the pregnancy. Moreover, we can do the diagnosis of the major fetal lethal abnormalities, and we can do the detection of the multiple pregnancies along with their chorionicity, and we all know that the chorionicity is the one which determines the outcome in the multiple pregnancies. And we can identify the women who are at the increased risk of preeclampsia and babies who are at the risk of IUGR and sudden death. We can do the screening for the neural tube defect by detecting internal translucency also. So 11 to 12 weeks is a kind of a gateway for a healthy pregnancy. The first marker which we have discussed is nipple translucency, and nipple translucency is nothing but just a collection of fluid under the skin behind the neck in the first trimester. It has got a criteria which has to be this, as I've told you, that NT is a very sound marker. It's only NT can carry the detection rate of 70%, so it has to be taken as per the criteria laid down by the FMS Society. With that, we will discuss our next in the webinar. The term NT you can use whether it is confined to the neck or it envelops the whole of the fetus, or it is septate as in case of cystic fibroma or not. The incidence rate of aneuploidy or any chromosomal abnormality is related to the size of the fetus, not just by the on the mere presence of the NT. NT is in aneuploidy babies usually resolve in the second trimester. So if somebody we taken a situation like this, suppose somebody has taken patient has gone for the NT has come out very high, and he comes back again to us after some time, and we saw we do the scan, repeated scan on her again, and we found that the NT is now has reduced. It doesn't mean that the baby's risk for the aneuploidy has gone down. The baby is still having because aneuploidy babies, the NT, the aneuploidy baby do resolve in the second trimester. In few cases, it may evolve into the either nuclear edema or increased nuclear pore thickness or cystic hygroma or even in the generalized hydrop. Second component, before going to the second component, let's interpret how the NT performs. The NT, if I plot NT across the chrominal length, the majority the NTs which are which falls within the 95th percentile, the babies those babies do well, and their 90s almost 97% of the babies, such babies, they remain alive and do well in their life. But still 3% babies which have anti-normal can have an aneuploidy. But if you go to the extreme of the spectrum, upper end of this graph, even those babies which are having a higher NT, even suppose at 6 NT at 6, a majority of the NT, such babies can still have a good perform well, and they are very healthy. As we all know, NT is associated with the aneuploidies along with the sudden death and major cardiac defects. So as you go by this graph, even at those fetuses which have a very high NT, like 50% of them may be normal, 10 in terms of the aneuploidy, 90% do well in utero, and more than 75% don't carry any abnormal defect. So higher NT doesn't gives you idea that this baby is absolutely abnormal, and just because the NT is very high, don't need to terminate. The silent point of this discussion is that even if the NT is normal, uh, for that gestational age, the fetus still can have an aneuploidy. So just don't rely on the presence of or the size of the NT. Do a test which can have a higher detection rate, like from a combined test or etc. Or if increased NT is there, it doesn't mean that there is a confirmed aneuploidy. Even at NT of 6 mm, 50% babies can still be euploid. So don't terminate just because there is an increased NT. Do evaluate it properly, and such babies of a big chunk of those babies can do well or be healthy. So the protocol is like, if I have taken the NT and if the NT is as per the FMS criteria, and if the NT is less than 3 mm, 3 or 3 mm, less than 3 mm, we go ahead with the combined test. If NT falls between 3 to 3.5 mm, either I can offer after counseling for NIPT or invasive testing. If the NT is more than 3.5, definitely we should go for the invasive testing, like CVS if you are able to, otherwise amniocentesis. Believe me, if you are skilled in CVS, the CVS carries almost similar risk as amniocentesis. The next component of a combined test is serum biochemistry, which includes PAPA and beta HCG. Now, as we have discussed, the newer quadruple test and penta test are are evolving, and they are studying SG, serum placental growth factor, and inhibin also. In the second trimester, only option left is the biochemical screening, which is called quadruple test, which is evolved by which are devised by the Howard Circle, and it carries a sensitivity rate of around 75%. Among the various sonographic biochemical marker, the one which in beta HCG and PAPA, how they perform in trisomy 21. In trisomy 21, 3 beta HCG is twice high as compared to the euploid babies, while PAPA is near around half of the euploid babies. But whenever we sending the report, sending the test for the laboratory for the combined test, the level of the serum biomarkers are affected by the machine reagent used, and can also be affected by the maternal age, gestational age, maternal weight, ethnicity, smoking status, and method of consumption. As we go one by one, maternal age is wrongly implicated, as we all know, the increase in the maternal age is associated with the increase in the background risk of the prior risk. Gestational age, if it is wrongly told, then as the gestational age increases, the risk decreases. Ethnicity wise, black women can have values of 3 beta CG high, as in the Pepe also high. But which is most important for us, that as in Indra we are doing only for ART cycles. So if the consumption is through the IVF cycle, as you can make out, the values of the in the pregnancy, the pre beta HCG in IVF cycles is on towards the higher side, and the PEPE is towards the lesser side, and which if not standardized for the method of consumption, we always be having a falsely high risk, because if it is not been mentioned as a uh, as consumption by the assisted reproduction. Neomarkers have come up, and as we all have discussed, that if we add on the neomarkers to our anti-combined test, we can get a better result, better sensitivity. We can achieve up to 97% of the detection rate. Neomarkers like nasal bone, presence and absence of the nasal bone, looking for the tricuspid regurgitation, looking for the facial angle, ductus venosus, and hepatic artery PI Doppler. These markers we'll discuss in the next webinar, how to take them, how to interpret them, how to put them in your counseling, and how to manage a patient with an abnormal marker. So if we go by, as we have discussed, that the assessment of pure marker increase the performance of our screening test, and it will end up in increasing the detection rate and decreasing the false positive rates. There are two school of thoughts how to go by to assess the these neo marker, is that either you, if you are skillful, or you can assess them in one go, then it's pretty good. Otherwise, for those patients who fall in the intermediate group of intermediate risk group, which contribute around 15% of such patients, for such patient uh, you can ask the patient to come up again. You can evaluate the newer markers in such patients and get the new risk. Next things come up is the when to do the combined screening test. As we, if we look at the biochemical markers as well as the NT, the difference between the biochemical marker from an euploid and trisomy 21 is maximum when the its gestational age is 11. And similarly, the difference in the fetal NT is greater when we take NT at 11 weeks rather than taking at 13 weeks. So the overall performance, if I look at collectively, the performance of the combined test is best when it is done at 11 weeks. Then it further decreases, and it's very minimal at 13 weeks. So it's the best time to do the combined test is if one go you have to do, then it should be done at 11 to 12 weeks. So how to interpret the results of combined test? The result of in a combined test comes as a risk as a one in something something. So you can divide that risk into three categories. One is low risk, intermediate risk, and high risk. Low risk when the risk is less than 1 in 1,000, and this low risk, if you are doing combined test for your whole of the population, then 83% of your population will fall in this category. And in this category, it still can contribute, can yield on trisomy 21 around 1%. So it's not foolproof procedure. So you have to consult the patient that this risk is there, but it's very low risk. You can go ahead easily. Second group is intermediate risk group, and third one is the high risk. High risk when the risk is 1 in 250, and it collectively around 2% of the population will contribute to the high risk, but it yields around 90% of the trisomy 21. Third category is intermediate risk when the risk is falls between the 1 in 250 to 1 in 1,000. So how to go by if the patient falls in the low risk group, we should go ahead. No more test is required. Directly go for the target scan. If patient falls in high risk group, then definitely it requires confirmation, diagnostic confirmation, and if you're comfortable, you can do CVS, or otherwise you can call to them at 16 weeks for amniocentesis. If a patient falls in an intermediate group, you can do two things. Either you can assess the new markers like facial bone, facial angle, nasal bone, ductus venosus, and calculate the newer risk. Still, the patient falls in the higher risk group, go for the invasive testing. If the patient after the newer risk, if the newer risk falls in a low risk category, go for the target scan. Now, twins always uh, is a challenging topic. It's and for aneuploidy screening also it brings a lot of changes, and because it carries it lot many options are not available for the aneuploidy screening. So limited options are there for the aneuploidy screening in terms of twins. Only option available, best option is the combined test. The advantage of doing the combined test for the twin is because it still has gotten a very decent detection rate of 75 to 80%, and it gives us a fetus specific risk instead of giving a pregnancy specific risk. And if you add on to doing more and more markers into their combined test, you will get in a very good specific fetal specific risk. If somehow because of the position, unfavorable position, and you NT cannot be taken, then options are still like very limited options are left. Only options left with you is either you can do quadruple test or NIPT. Quadruple do test, if you do at 16 weeks, the performance of this test is very average. Like it has got a detection rate of around 60 to 65% with a very high false positive rate and false negative rate. But it gives you fetus specific rates, and it's low cost. So if you have not done combined test for the twins, the next option left with is quadruple test, and third one is NIPT, which is highly sensitive because it has got a detection rate of more than 90% for the twins, but it doesn't give you fetus specific risks. Now newer and newer changes are coming up. Sooner we may get an NIPT which can give you fetus specific risks also, but right now till now we don't have such NIPT. But and moreover NIPT is very costly. If NIPT comes, another disadvantage of doing NIPT in twins is that if NIPT comes high risk, then I have to do the invasive testing for both of the fetus, which again increase or the risk of abortion because of the doing the amniocentesis for both the fetuses. For triplet, no screening test is available, and we have to restrict our screening to the use of NT and other USG markers. Few more problems arises while thinking of or while doing the aneuploidy screening. Among them is if we have it's a multiple pregnancy and one of the features has demise. The nucleoid group has again come up with a solution for this. If you are done you are doing an NT scan and you are not seeing any it was a multiple pregnancy and now it has one fetus is demise, and but you are not seeing any part of the fetal pool in 12-week scan, then definitely you can go ahead with the first trimester combined test. But if you're seeing still seeing on 12-week scan some portion of the fetal pool is there, then don't do combined tests because that existing features may affect the biochemical level of the markers, and the testing haywire. Next problem which may arise for doing aneuploidy screening is the when patient comes to the ongoing bleeding. How ongoing bleeding affects the biochemical markers. Studies have shown that the biochemical marker they may get affected because the serum levels get affected, and so is the false positive rates. But USG markers are not affected. Many studies are done, and they have come up with various things, various results that you can do it, you cannot do it, you can do it after a certain of time amount of time. So conclusion of those things is that the meta-analysis says that you can wait for the bleeding to stop before doing the scanning, but even if you are not, you have done aneuploid screening, even while the patient is bleeding, it won't jeopardize your results. The the latest in the town is NIPT. It's a newer test which depends upon the detection of the cell-free fetal DNA. These cells are trophoblastic cells which break down from the trophoblast and comes into the mother, and those fetal DNA then will be compared against the maternal genome, lymphocyte genome, and through the SNP process, and the risk is assessed. This is very highly sensitive test. The advantage it carries is that it's very highly sensitive, carries a detection rate of 99.9. It's non-invasive, so no risk of abortion, which is there with invasive testing, CVS and amniocentesis. And along with the aneuploidy, you can have screen for the multiple microdeletions. Like now, the newer NIPTs can detect up to 60 microdeletions, like Angelman syndrome, Takuru-Riches, Dijot syndrome, and so on and so on. It has got a very high positive predictive value, so that once you have done so, the need of the invasive testing falls drastically. The disadvantage associated with the NIPT is that it's very costly, and as it's around, like, the cost of the single NIPT may cost you around 20 to 25,000, and patient, it may not suit to the pocket of the patient. And second thing, it still is a screening test, not a confirmatory test, because the DNA which we are testing here are trophoblastic cells, DNA of the trophoblast, not the proper of the fetus genome. That's why it's not a confirmatory or diagnostic test. If it comes high risk or intermediate, then we again have to perform amniocentesis or CVS. So again, it multiplies the cost associated with it. In twins, it doesn't give you fetus specific risks. As I told you, newer NIPT may come up with an answer for this, but till date, NIPT doesn't give fetus specific risk. So if risk is high, I have to do amniocentesis for both the fetuses. In case of a vanishing twin, again the reports of NIPTs are not reliable, and for triplets and more, it cannot be done. So how to interpret the reports of NIPT? Again, how to include NIPT in your protocol. Like if you have done any screening test, whether you have done your first trimester combined test, or you have done quadruple test for your patient, the risk will be like they will be falling either in the lower group, in high risk, and intermediate group. For the low risk group, there is nothing, no problem. You can go ahead with the target scan. For high risk, again, there is no role of NIPT. You have to do CVS or amniocentesis. But where NIPT can fall in is intermediate risk group. For this group, you can do NIPT instead of going for the newer marker, and you can assess the newer risk. If the risk is low, then definitely you can go for the target scan, and the risk is high, then you have to do CVS or amniocentesis. So at right now, the present role of NIPT is that it can be offered to the intermediate group after the conventional screening testing is done, or for those mother who are conceived at the advanced maternal age with a self egg, and they don't want to go with a screening test with they want to go with a screening test which have gotten a very high precision. So if an NIPT reports has come up positive, how to proceed? So if it is a positive for trisomy 21, you have to consider CVS rather than amnio. And if it's come positive for 18 and 13, then look for the USG marker for the trisomy 18 31. And before going ahead with any further testing, if there are USG markers are there, definitely go for the CVS. Don't wait for the amniocentesis. But there are no marker for the ultrasound marker for the trisomy 18 and 13. Then do amniocentesis and synthesis rather than doing CVS. If it is negative, then it will drastically decreases the need for the amniocentesis or invasive testing. If the NT is less than 3.5 and you have done NIPT, then there is no need of further testing. If NT is more than 3.5 and it's a baby is carrying any major structural anomaly, rather than even if still you have done NIPT and it's low risk, still go ahead with the invasive testing or the CGS micro. One disadvantage of NIPT is that because of the maternal weight, or less, or because of the obesity, or because of the if you're doing it very early gestation age, there sometimes testing may not be done, or test report may not be generated because of the low fetal fraction. If such is the thing, then do the detailed scan. If there is no abnormal finding, repeat the NIPT test, and if the repeat test comes good, okay, no need of doing any invasive testing. If the test again fails, look for the priority risk for the trisomy 21, which is the age risk or the prior risk or the background risk. If that risk is high, consider invasive testing. If the risk is low, there is no need of doing invasive testing. But if you have done the detailed scan and there is abnormal finding, then definitely no look back, go ahead with direct invasive testing. So the present day recommendation by all international society, be it ACOG, NHS, ISWAG, FMF, SOGC, that all the pregnant women, regardless of the age, should be offered through an informed counseling process the option of prenatal screening test. Uh, uh, we have finished up with our lecture. Now I'll show you some algorithms how to go ahead in various situations. First is for single live intrauterine gestation. So for single live intrauterine gestation pregnancies, do NT scans at 12 to 14 weeks. If the NT is done as per the if you are able to do the NT and NT is taken as per the FMS criteria and NT falls less than 3 mm, do the combined test for that patient. If NT is between 3 and 3.5 mm, do NIPT or invasive testing after the proper counseling. If NT is more than 3.5 mm or nasal bone is absent, do the invasive testing. If because of the position, because of any other reason, you are not able to do the to take the NT as per the FMF criteria, even after multiple attempts, ask the patient to come again at the 16 week for the fetal genetic sonogram. Look for the nuchal fold thickness, nasal bone length, what ventriculomegaly, print right subclavian artery, short femur length, and any structural abnormality. If everything is normal, go ahead with the quadruple test, and if anything is abnormal, do the invasive testing. As we have discussed, if you are doing combined test or quadruple test, the risk comes in the form of low risk, intermediate risk, and high risk. For low risk, nothing is required. Further testing is required. You can go ahead with it with the target scan. For intermediate risk, you can opt for the NIPT, and if the NIPT risk comes low, there is you can assure the patient and go for the target scan. If NIPT comes of higher risk or combined test, initial combined screening test has come up a higher risk, then you have to do the invasive test. Next algorithm is that if there is a twin on a confirmation scan, be it a dichorionic or a monochorionic, call again the patient after 3 weeks and do the first trimester scan at 9 weeks. And that at that time, if suppose it's one fetus has demised, there is single live pregnancy with one missed abortion, or another possibility is can be that both the babies are still doing well. In both the cases, call the patient again after 3 weeks, do the NT, perform the NT scans, and in such now few scenarios may come up that the single live uterine pregnancy with 1 MA which was there in 9 weeks now must, and there is only single live uterine pregnancy with, and now there is no sign and symptoms of the second fetus is present over there. Second possibility can be that it's a single live uterine pregnancy with one missed abortion, and F2 is the fetus 2 is present but it's not having any cardiac activity. And third is that both the twins are doing well. So in case where there is a single live uterine and there is no sign and symptom of the F2 fetal pole is not present, you can follow this pregnancy as a single live uterine pregnancy and follow the algorithm for what we have discussed for the single live uterine pregnancy. For those babies where there is for that pregnancies where there is single live uterine pregnancy with a one missed abortion and the fetus is present, do the NT test, NT scan, look for the other sonographic marker also. If NT and nasal bone is taken as per the FMF criteria and NT is normal, call the patient after 4 weeks for the fetal genetic sonogram. If second option is if NT is more than 3 mm or in nasal bone is absent, do invasive testing for this patient. There is no option left. If NT is not taken as per the FMF criteria, again call the patient for after 4 weeks for the fetal genetic sonogram at 16 weeks. Look for the second trimester sonographic marker like nasal bone, nipple fold thickness, ventriculomegaly, ARSA, and short femur length, and any structural abnormality. Nothing is wrong. If nothing is wrong with the fetus, then you can go ahead with the target scan. If anything is abnormal, then you have to do invasive testing. If the invasive testing is normal, you can assure the patient that the baby is perfectly all right and just go ahead with the target scan. If invasive testing comes abnormal, any genetic abnormality is there, go ahead with the termination of the pregnancy. For the twins, if there is a twin pregnancy at 12 weeks, be it a dichorionic or a monochronic pregnancy, try to take the NT and nasal bone as per the FMF criteria. If the NT is less than 3 for the both fetuses, then go ahead with the combined test. If NT is lying down between 3 to 3.5 for any one of the features or both the fetuses, then you can go ahead with the NIPT or invasive testing of that one particular fetus or both the fetuses. If NT is more than 3.5 or a nasal bone is absent for either one of the fetus or both the fetuses, only thing that left is with the U is invasive testing. If somehow because of any reason you are not able to do the NT or NB test, then call the patient for the genetic sonogram at 16 week. Look for the second trimester sonographic marker. If everything is normal, go for the combined test or NIPT. Quadruple test or NIPT. Anything which is low risk, you can assure the patient and will go for the target scan. If intermediate risk, you can still counsel the patient for the like they can go for the target scan, NIPT, invasive, whatever they want. If high risk, invasive testing only is recommended. If anything is abnormal in the second trimester, again invasive testing is required. For the triplet, do because we have learned in this session that for triplet there is no kind of aneuploidy screening test is available. We have to rely only on the ultrasound. So do NT scan and try to evaluate as many possible USG marker and try to do the first trimester anomaly scan if possible. And we all know that the triplet can be TCTA, DCTA, or monoclonic triamniotic. If it is a TCTA option left, either you can do the one of the fetal reduction with the KCL, or you can continue the triplet with the ether. For DCTA, there are three options left. Either you consult them for the reduction of twin pair with the KCL, or reduction of the one of the monoclonic twin by the laser, interstitial lasers, or you can continue the triplet with the answer class. Among them, the preferred one is by reducing the twin pair. And a very rare entity can be there which is monochlorinic triamniotic, which is very rare but can happen. If it's so, then option left is only an option left is to reduce the one of the monochlorinic twin by the laser, or if you can continue the triplet with encircular. That ends our algorithms for the singleton, twins, and triplet, or the twins with one missed abortion. Thank you and thanks a lot. I hope you'll abide with the algorithms we have designed. So we go to the poll again. Look, uh, we'll we'll go to the questions again and see how. I'll ask you to poll once again. It's the first question. So this is a 21-year-old female who had a primary malaria due to mosaic Turner syndrome, but having a bleeding only on with the medicine, conceived through ART, now having a pregnancy of 12 weeks, came for a genetic counseling about the possibility of aneuploidy in her child. What will you offer? The options are karyotype, NIPT, combined test, and no testing is required. I feel so, but don't go by the this that the mother is mosaic Turner because though she is Turner, she has conceived through the donor cycle. So combined test is the only option right now here. Fetal karyotype is not required. NIPT again not required because it's a uh, pregnancy through the donor egg, and the best option available is over here is to do the combined test for the patient. Let's go to the next question. 21-year-old female conceived through ICSI with her self-egg and donor sperm because of the male infertility, and now she's carrying 11 of single intrauterine pregnancy. How does she require any Aneuploidy screening tests? Definitely yes, as we all know that if anybody, even a woman of an 18-year-old, can have an aneuploidy. So definitely aneuploidy screening should be done universally for all women, whether they have conceived a self-egg or they have gone with a younger woman who have gone with a self-egg, or elder woman who have gone with a donor egg of a younger age group. So it should be done universally for in all of the patients. There is no ifs and buts in this. Third question, 30-year-old female anxious patient because of bleeding came to you at 11 weeks, bleeding. Anti comes normal, but there is subchorionic hematoma. So we have, as we have discussed, even there is no uh, defined consensus on whether we should do or not do. But still, the best approach is to wait for a patient, wait for bleeding to stop, and do it after some time once the bleeding stops, because it give a logic that if the bleeding is going on there, it may affect the serum level, especially of the biomarker. So the best option is to ask the patient to come up after 1 week once the bleeding is stopped, do the combined test. But even if you do it, if you have done it, it will not jeopardize your reports. So the best option is right now is to do test after a week when the once the bleeding is stopped. But all of the answers are okay, but best among them still the best is the one to do it when the bleeding stops. Next is USG at 12 weeks shows DCDA twin with CRL of one baby is 16 mm CRL, another in 57. The one with the 57 mm has got demise. There is no cardiac activity in that one. And during the lecture we have discussed that uh, if the baby is still there, fetal pole is seen in the 12-week scan, we should not go ahead with the combined test. And only option left is to rely only on the ULC marker rather than doing any kind of a screening test. You cannot do you cannot do NIPT in such cases. You cannot do the biochemical markers in such cases. So the only left option left is to rely only on the USG marker for such patients. So no need, no more tests is required, as NT is normal is the best option.
think we should allow them to vote 10 seconds.
Hmm.
We'll give you 10-15 seconds to vote. After that, we'll start the discussion because last question still people were voting for combined test and NIPT, but in the last slides we saw that NIPT or combined test is not a good option when you still have the fetus present there. So next question is single live intrauterine gestation of 12 weeks 6 days with cystic swelling with septations behind the neck. NT is 3.6. What is your next plan? Okay.
Uh, Still, some people are voting
For combined test.
for combined test and IPT. NT with 3.6 with septation, it goes for the cystic hygroma, but whether septations are there or not, it doesn't mean. But in any NT more than 3.5 should go for invasive, and only invasive testing. That is CVS or anything. So 38-year-old female who had conceived from an XC with a donor age. Uh, NT was normal, the NT of 1.2 mm, gone for the combined test, report says high risk, 1 into 231, and this is what your report says. So you have to look into the report in toto. Lot many informations are there. Whether the age is taken up correctly, whether the gestation age was taken up correctly, whether the maternal weight was taken up correctly, whether it's what is mentioned, or what is the nature of conception has been mentioned or there not. All those things should be taken into consideration before terming that report as a normal or abnormal. So in this case, since she has gone uh, with a donor age, A group, but here the age at the term, here at the age at the term is still 39, which is her age. So age of the donor was not been considered in this test while evaluating the risk for the trisomies. That's why it has falsely been increased. So in such cases, the best.
Yes.
Yeah. So in such cases, you should ask the laboratory to repeat the statics again and give you a newer report with the corrected age. So the option with now, so there is no need of termination. Definitely, NIPT and karyotype is not required because the risk is falsely increased because uh, age is wrongly mentioned, and the best way is to go ahead to get the new report from the laboratory by correcting the dates. So none of the answer above is the best answer. In this case, 32-year-old female has conceived with an XC with the self eggs, and NT is normal with NT and 1.2 mm, but her combined risk shows report with high risk for the trisomy 1 is to 243. Here is the report, actual report. I think none of them.
I think all of you can enlarge the report and see. So pay stress on the pregnancy details, which is very important. The gestational age is based on CRL or whether they have mentioned assisted reproduction, how they have classified the pregnancy. Obviously, self eggs. So age at term is correctly mentioned as 33. But if you see the difference between this report and the previous report, the gestational age is based on ART written assisted reproduction in the previous report. Here they have mentioned CRL based reporting.
So it means they have considered this as a natural consumption, and they have take mode of consumption is natural in this case. That's why, and not it's not in a and not in a IVF. That's why the modification has not been done for the values according to the ART cycles. That's why it has gone wrong. So again, it's in such cases better to do a get the new report from the laboratory and decide accordingly, rather than jumping to the conclusion just on the false report, which has been generated because the modification has been not been done. Next case, it's a patient who is conceived after 7 IVF failure, now at 12 weeks, carrying monochlonic pregnancy with the one fetus having NT of 3 mm and another one having an NT of 1.6 mm. How are you going to consolidate this patient? And I'll load I'll load picture of this kind of screening. This is monochronic pregnancy. So fetus is having an NT high NT, another fetus is having a normal NT. How are you going to proceed?
So please, everyone, you will have to vote again because we have uh, closed that poll and started the picture. So you can start the poll again. For people who have voted, also you can again vote.
This is a bit tough question, and that's why a lot of diversified answers, CVS, NIPT, combined test.
You can.
So since we know that this is a monochronic kind of clinic, and in monochronic kind of clinics, we all know that genotype of the both the babies is going to be the same. Even if the one baby is NT high and another baby is NT normal, it doesn't mean that the one with the NT is normal is having a genotype normal, and one with the NT which is having higher NT, the carrying an that baby may be carrying anybody. It will not be so. So when the genome is genotype of both the baby is going to be the same. Uh, in this case, since one this discrepancy in NT between the two fetuses gives you idea of more of the having this pregnancy carries a risk of PTTS rather than aneuploidy. So here again, since it's only 3 NT, best way to go ahead is to do the combined test for this fetus, and then both the babies. Look for the USG markers as we have discussed. For the twin, the best test is available is combined test. Do the combined test. But if combined test is perfectly normal, to do anything. If combined test comes up higher, then definitely do amniocentesis in this case for the one with the baby with the increased NT. One amniocentesis is enough because it's again a monochronic pregnancy. So both the genome of the baby is going to be the same. Next question: elderly woman at 41 years have conceived with a donor egg. Her NT scan was normal with NT 2.5 at 12 weeks, 4 days. Combined test shows risk of trisomy 21 as 1 in 225. It's a simple answer question, I feel so, but still some people are opting for risk is high.
No testing. No, 20 more than 2.5 or it's
I think something has gone wrong with this question. It's we have already discussed that the risk is that high risk group it means if the risk is more than 1 in 250. Some book says 1 in 300 also, but here the risk is 1 in 225. So definitely this patient requires only invasive testing, which is karyotype. A few people still click for no testing, NIPT and quadruple test, which should not be done.
question.
Last question: elderly female with 37-year age conceived with self eggs. NT at 12 weeks was 3 fetal karyotype and NIPT was offered. She chose an NIPT and fetal fraction was not being, a report cannot be generated because low fetal fraction. Your plan for this patient?
Again, they don't charge.
No, they don't.
NT
NT, but still, okay. Again, a difficult question to choose. Difficult options are also difficult. Though she is elderly and NT is on the borderline, it doesn't mean that the baby is going to be the abnormal. We have to give all our doubts. We have to leave all our doubts behind, and we have to stick to the protocols. That again, this patient's since the NIPT has been done, and NIPT is fetal fraction is low. That's why the report will not be generated. Since it's only the first time report is not generated, better to go again with the report repeat sample. The companies of NIPT don't charge if you are if it's such situation arises, they will not charge the patient to go for the next NIPT. Again, if the next NIPT again comes up with an report has been not generated because of the low fetal fraction, then in such cases, in only in such cases you have to go for the amniocentesis if the background risk or the prior risk is high. I hope you have understood the logic behind, and I feel you must this session must have increased your wisdom towards towards aneuploidies and how to proceed in them, how to give the best evidence-based practice or services to your patients.
So thank you, Dr. Vipin. We now keep the floor open for any questions you might have. I see Dr. Anuja has asked if a quadruple test shows high risk for neural tube defect, then should we go for NIPT or rely on USG?
The neural tube defects, for neural tube defect, the marker is alpha fetoprotein. If it is raised, it will give you definitely will give you a higher risk for it. But the sensitivity of ultrasound is 100% for neural tube defect. So just don't do NIPT. And you won't get any information of from the NIPT if there is a risk of a neural tube defect is there. Better to ask the patient to come down as soon as possible, do the thorough assessment of the spine in all possible views. If spine is perfectly normal, no need to go for any sort of karyotype or invasive testing.
Dr. Shubdeep is asking, is aneuploidy screening needed if PGS was done already?
Not required.
What to do in nuchal cord? Mean of tube measurements or call again? What to do in nuchal cord?
So, okay. So if the patient, if the around 5% of the babies do come up with this situation where there is a nuchal cord is there around the neck, and in such situations, taking the NT is bit difficult. If you have taken the NT and your image matches of the FMF criteria, better to take the NT above and below the nuchal cord and take the mean out of it, and then give the average NT for the calculation of the aneuploidy risk, rather than just relying on only on the portion above the cord. There will be fullness that where the NT will be high. So if you go only by that NT, then definitely the risk will be going to be the falsely high. So best to do take the average NT and go for the combined test.
Okay, next question from Dr. Jha. If vanishing twins, then we should do only age and NT based assessment?
Yeah. If the fetal pool is still existing, then no further test. You can't do NIPT, you can't do combined test, only you have to rely on NT and other USG marker. That's all.
Any other questions anyone has? Please type in. So Dr. Shubdeep, some companies have come up with NIPT for twins. Are they reliable?
Yeah, it's still as I told you in my session that till now the foolproof is that they are not very much reliable. But as the science evolves, further evolves, we may get in a certain NIPT test which are companies which can be relied on. But for the moment, yes, we have to keep our finger crossed, and let's wait for the good number of reports have been generated, good number of reports have been come out, which says that this this is a valid test.
Dr. Anuja, in a case of twin pregnancy with missed abortion with only gestational sac visible, should we go for combined test?
Definitely you can go ahead with it.
Dr. Shubdeep, NGS in aneuploidy screening. NGS in aneuploidy screening.
NGS, again, for that you require invasive testing. If you're doing it NGS for PGD, PGS, that's okay. But if you're doing in ongoing pregnancy, only way is to do is by uh, mm, invasive testing, which is not recommended for all.
Dr. Manjula, is combined test reliable in pre-existing diabetes patient?
Definitely, there is
Uh,
no relation between the diabetes and any if or uh, combined test reports go wrong anyway.
or will GDM affect NIPT results?
No, not at all.
Okay. Dr. Sonal, need of aneuploidy screening if PGS already done. This we've already answered, Dr. Sonal, that if you have done PGS, there's no requirement for aneuploidy screening. Dr. Shubdeep, again, how does bleeding after the sorry, I can't after the biochemistry of combined test? How does bleeding alter the biochemistry of combined test?
Some report says some publications are there which says that if the ongoing bleeding is there, then the markers, biochemical marker, serum beta-sectin pathway, they may go wrong, and they that's why the false positive rate may be on higher side for such cases. But confusing reports are there. Some says there is no, it won't get affected. So that's why, as I discussed, that there is no consensus on this matter. You can definitely go ahead with the combined test then and there also, but it seems logical. Patient is bleeding, and she's must be more worried about uh, safety of the pregnancy rather than aneuploidy that time. So let the it's logical that let's wait for some time, let the bleeding stop, and her mental status will also be in the normal state, and then we can throw up them for about the aneuploidy and all.
Dr. Sonal, please explain about the pentad test again.
It's just an expansion of a newer conventional combined test. Here they have taken up markers like uh, NT and nasal bone, but along with the uh, uh, combined test as we are doing, we are doing PAPA and 3 beta 3 here, alpha fetoprotein, SGLF, and is used along with the uh, mm, PAPA.
Pape, free beta
This
CG,
is an
inhibin.
inhibin.
Yeah.
and the the sensitivity of this is very high, but still it's in an evaluation phase, and it's in European countries. Some companies are offering it. In India, it's not been yet come up yet, but we are also trying hunting out for this test on or the first trimester quadruple. Once we able to negotiate with the companies, we may throw you on the we will intimate you about this, and it will be a big tool to you in the sense that though if you are not able to do a NT for the patients, you can do the first trimester quadruple, which is as good as the second trimester quadruple. So till now, let's keep our finger crossed. Once the deals have been finalized, or things have this test is being validated in India, we'll definitely come up and we'll put this in our protocol also.
Next question is from Dr. Sutapan. If the combined test is normal, should we go for quadruple test again?
Not required, because once you have done the combined test, which carries a which itself has gotten, which is a very good test, having a sensitivity of 95%, then once you've done a better test, there is no going no role of no way you go to go back and do a test which is a weaker test, and not as good as good as combined test. So you should, once you have done a better test, no need of doing the test which is lesser sensitive.
Dr. Jyoti Gupta, what do you suggest for karyotype, fish, CGH, or karyolite?
We will discuss this in there is a Dr. Kshitij must be putting a calendar of webinars we'll be having in next 3-4 months. It will be like on lot many topics. Will be one topic. One of the webinar will be totally dedicated to the genetics which we require in our day-to-day life for obstetricians. We'll answer this thing in that topic. But yeah, briefly I tell you, karyotype is just an give you morphology of the various chromosomes you have. What else you have asked?
Fish, CGH, karyolite. Dr. Jyoti, we'll be having an exclusive seminar from a speaker from Harvard University on the different genetic platforms that we have for testing, whether it's a fish platform or a CGH or microarrays that they've recently come up or karyolite. Microarrays by far is the best test that you can have on an amniotic fluid sample because the detection rate is very high compared to a conventional karyotype or a fish test. So we are in a process of shifting to microarray based amniotic fluid sampling testing from the conventional to this. So maybe in next 15 days or a month we might do microarrays for all the amniotic and CVS samples that we have. Yeah, and we'll have a webinar on exclusively on the uh, on these technologies like what is fish, what is CGH, what is microarray, what is NGS, what is a conventional karyotype, what are the band resolutions for all of these. So next week probably we'll have a seminar on that as well. So that would make things more clear to you. Dr. Akshay has asked how to interpret FHR as a USG marker.
Yeah, this is a good question. I'll be dealing with this FHR in my next session, but I'll give you some hint of it. FHR is again a marker, USG marker. FHR doesn't help in picking up the trisomy 21 because it is only mildly affected, but it's a very good tool to distinguish between the trisomy 13 and 18. For trisomy 13, it's markedly high. They are tachycardic and having a very high fetal heart rate going beyond the 95th percentile, while in case of the trisomy 18, it's mildly decreased. So since both of the trisomy 8, 13, 13, they have got a almost similar USG picture where we cannot distinguish whether it's a trisomy 18, 13. FHR will give us an idea whether this is a trisomy 13 or 18. If it is a tachycardia, then definitely it's a trisomy 13, and bradycardia, then definitely it's trisomy 18.
Next question is from Dr. Tanya. In case of invasive testing for raised risk on serum screening, should we go for microarray in all cases or fish QF-PCR karyotype as was done? Again, I think that's the same thing, Dr. Tanya. We'll take up this question largely in the next webinar when we have should we go for microarray or fish or QF-PCR or karyotype in invasive testing.
Yeah. For if any risk in you have done any kind of screening test, if the risk is high, definitely you have to do the invasive testing, and in that invasive testing you can do karyotype, you can do microarray, you can do only these two things. Fish is a complementary because fish just tell you about the pure aneuploidies, maximum you can say 5 or 6, but since once you are doing invasive testing, you should go for the test which can tell you about the maximum number of chromosomes or whole of the karyotype of the fetus. So fish should be just the complementary, it should not be done in a isolated cases. So either karyotype with the fish or microarray with the fish, because fish gives you an idea about the aneuploidies in a 2 hour or so, very minimal time. But karyotype takes time. That's why it should be complemented with the karyotype.
Dr. Sasmita, next question. What is the range beyond which we call tachycardia in first trimester?
There is a wait like once in around 6 weeks when fetal heart arises. It's around 90 to 100, and from there it goes on increasing and reaches up to the 180, 190 by 9 weeks or so. After that, again it falls by the rate of around 1 beats per minute, and it's throughout the gestation till term, and by term it reaches around 120, 125, 130. So 180 up to 190, it's okay if you are getting such high rates at 9 to 10 weeks around.
Dr. Akshay again. Does each pregnancy needs combined test? I think Dr. Akshay, there was one slide which had just mentioned this only, that irrespective of whatever age you have, all societies recommend prenatal screening or aneuploidy screening for all patients. It is very important for all patients. In multiple, I did not get it, Dr. Akshay. You're saying in multiple pregnancy? Okay, till that time, we take the next question from Dr. Prerna. She said, if fetal reduction has been done, then how to screen for remaining twins?
If it is a triplet pregnancy, as I told you, there is no tool available right now to look for the aneuploidy screening. Only you have to rely on the USG marker and NT, and better to do the kind of first trimester anomaly scan also along with that. Only on that basis you have to rely to which fetus produced, and then the one which is having the maximum highest measurement of the NT or any and USG marker which is abnormal, that fetus you have to select for the reduction. And for the rest of the two fetuses, there is no way you can do any testing.
So Dr. Manjula wants to listen to that tachycardia once again. If it's above 189.
Yeah, if it is above 180, 190, then definitely it's tachycardia. It's more than 95th percentile in that for that gestation is that.
They're asking if in the first trimester we find tachy or brady, what is the further management?
Uh, Line of action will not change much. If it is a bradycardia, uh, definitely you can add on like Vicelon, prednisolone, or Barglov to that pregnancy, and you can add on aspirin and low molecular weight heparin, because we have seen certain cases where amniotic sac gastric sac is small and there is a fetal bradycardia. With the addition of these things, things may improve autism, but it doesn't mean that bradycardia means 80 heartbeats at 6 weeks doesn't mean it's bradycardia. It's still good. Below 80, it's okay. So anything between 100 to 80, there is still a pretty good handsome chance that the baby may survive in a normal fashion.
Viceron dose and duration.
Vicelon again, dose has to be as per the look into the patient's profile in toto. If there is a previous history of RPL and all, you should keep the doses at towards the higher side. Like you can keep 10 milligram BD or 5 milligram PDS, and then you can taper it off after 12.
Dr. Akshay is asking, in second gravida, do you need combined test? What is the risk of down?
Second gravida.
He is asking, do all pregnancies require?
So even if she can conceive for the second time or third time or whatever number of time, she should undergo combined test or any kind of screening test always for whatever pregnancy number of pregnancies is there.
Any further questions anyone has? I think it was a very informative session for all of us. If you still have questions, you can keep posting on the WhatsApp group now. Um, as of now, we come to conclude the session. Thank you, Dr. Vipin, for the very interactive and very informative lecture. I just see one more question, Bhaglob dose and duration also. So if you can just specify that.
Bar glow is required. bar globe is required when there is a case of RIF, RPL, and for RIF you can continue the bar globe of 16.5% IM from the day of PT till the placentation happens of first phase of the placentation has happened up completely, like 14 weeks or so. And for RPL, you have to continue this bar globe therapy, immunotherapy for around 28 weeks or so.
Every 3 weeks.
Every 3 weeks, every
So
21 days.
Baglob every 21 days
Till 14 weeks for RIF and for 28 weeks for RPL.
All right. Thank you everyone for attending the webinar. If you still have some questions, you can just keep posting on the WhatsApp group, and Dr. Vipin would be kind enough to answer more queries. I think it's a lot of questions that he's already answered, but you can still post if you have queries, and we'll keep this fetal medicine webinars going on continuously for the next 1.5 months. Yeah. So, or second point, he has shown some algorithms. We'll try and post it on WhatsApp group, the algorithms once again for all of you to refer. These are the SOPs that we would make. If anyone has any different opinion or has read anything or has heard anything different from his lecture, please feel free to put it in that group that we have heard that this is little different from the lecture that you have given. We would all again discuss, go back to the studies and come to a conclusion where we all can make a better SOP for our patients. So we'll try and put those algorithms on WhatsApp. If you differ in the opinions, please feel free to put it. Else, I would request everyone to follow the algorithms laid down and give a proper care to your patients. Thank you everyone. Thank you once again for joining this webinar.